7. 7 plus 12 was 9.
Wait, you're going live now, so just hold on. You're live now.
Okay. Good evening, everyone. Today we are going to be having a quick discussion on management of Haematuria. This will be our second episode of our monthly teachings, and it's just so that we can have a brief and a good understanding of what management of Haematuria looks like. So I'll just proceed now. It looks like we have a good number of people in the meeting already. So okay, so the objectives of the presentation basically is how to define a material. You want to know how to classify a material when you see one. You want to be able to differentiate a material from its mimics. And you also want to be able to recognize common causes of a material. And also understanding the initial management of a material. Identifying the need for a urgent referral to a urologist and nephrologist. Understanding the need for further investigations and definitive management of the material. The material is something that fascinates both the nephrologist and the urologist, but not all cases of hematuria will go to the nephrologist. So you have to decide which one is going to go to the nephrologist and the one that is going to go to the urologist. So the aim at the end of the session is we should have a good knowledge of the common causes of hematuria, its differentials, able to identify the signs and symptoms, and its initial management, and also further management, and also identify when to urgently refer to urologist. Because this discussion will be streamlined to management of material on from the urology perspective. So there are some pre-assessment questions here, just to have test our knowledge, and it will be good. I think there will be a poll for us to answer the questions, and so at the end of the day we can see how what our knowledge was before before this presentation and also after this presentation. So people can start answering the questions, please. I'm just thinking I'll just give some few minutes for everyone to answer the questions before I proceed, so I'm not too fast. Okay, I think we're on the second question now. So on the third now. I hope everyone is getting to see the questions, the polls, and able to respond. So I think the fourth one is just sorted out now. Yeah, I think we're done with the assessment questions now. We will just proceed. Okay, so what is hematuria? I mean, I think everybody, when we see maybe a patient's urine or urine anywhere, and we see a tinge of blood, I mean, we easily recognize that as hematuria. So, hematuria is the presence of blood in the urine and can originate anywhere in the urinary tract. Hematuria is defined as presence of at least 5 red blood cells per high power field in 3 consecutive centrifuge specimens obtained at least 7 days apart. And hematuria is actually a common presentation and emergency in urology. And it's good to know that it's not a diagnosis in itself. So you need to identify its underlying cause. So if you see in a case of hematuria as a GP, as a primary care physician, or as someone working in the hospital in the secondary practice, you need to identify why the hematuria is happening and know if is it a physiological one, is it a pathological one, why is this happening? So you need to ask yourself questions. So it's good to know that hematuria in itself is not a diagnosis, and it's been classified as visible hematuria or non-visible hematuria, VHNVH, just acronyms. And you, in time past, hematuria was classified as gross hematuria or microscopic hematuria, basically. So why do you have to get worried about hematuria when you see a case of one? I mean, hematuria is just like bleeding from. It's just like bleeding. I mean, it's ongoing bleeding, and we know that bleeding is one of the things we are always worried about in medicine. And ongoing bleeding can cause anemia in itself, and it also has attendant consequences. And I mean, there was a there was an interesting scenario, a case study I read about. I mean, Wonderlich syndrome, which I mean, not a very common cause of hematuria. It's just, I mean, in that particular patient, it was more of like anything causing Vassava maneuver, coughing, defecation was causing her to bleed. And why was she bleeding? She had this intraparenchymal renal artery aneurysm, and she dropped that HB so fast by the time she presented in the hospital. So, I mean, so hematuria can result in anemia. Not commonly, but it can. So the other problems with hematuria is it can, especially though, I mean, the ones that are non-glomerular in origin, we'll talk about that later. It can result in clot formation. And if you're having too much of clot in the in the bladder, it could also affect outflow. So the patient can be in urinary retention. It can later obstruct the urinary tract. That's also a nodus for infection. And if there's obstruction of urinary tract, also it can lead to an acute kidney injury. And hematuria also connotes a sinister pathology in the fact that it could just be a cancer that is just manifesting itself. And it could also be a glomerulonephritis, which is also a common scenario. And sometimes you also expect hematuria, we'll say iatrogenic, but I mean, so for example, if someone has just had a cystoscopy procedure or a procedure along the urinary tract can cause hematuria, we expect that to settle, and it could also, hematuria could also occur following surgeries like transurethral resection of the prostate or transrectal resection, and also TOPS. So the origin of hematuria could also be glomerular or extraglomerular. We know the glomerular is the unit of the kidney, an important unit of the kidney. But sometimes when this is also affected, it causes hematuria. And most of the cases, a whole range of those that are glomerular are medical in nature, and the nephrologist will be the one to manage that. So this is just a picture, just to show us the different shades of hematuria. And from the far left, we can see that there's a tinge of blood to say. So the different words we can use to describe it is clear pink. In the second one, we can appreciate the pinkish nature. So different names there. Watermelon, yeah, it looks like a watermelon. Rose. So there are different words that people use to describe this thing. So I mean, when you are, so that this can just help you when you're discussing with a fellow clinician or a urologist. And the next one looks, it looks more bloody compared to the first two. Uh, Different names also to describe it. And the fourth one looks, classically, you say this is bloody. And the fifth one is bloody. Yeah. Yeah, the other shades you can see dark brown, tea colored. I mean, especially when you are seeing cases of hemolysis, that those are also cases when you see hematuria. Okay, so this is a good picture just to show us. Urine in the bag. Obviously, this is hematuria. So, like I said earlier, hematuria is either visible or non-visible. Visible, usually called gross hematuria in times past. Also macroscopic. When you say visible hematuria, it's plain to everyone that this is patient is having hematuria. It is hematuria. You can't argue it. And the next one is non-visible hematuria, which we say is mostly microscopic or dipstick positive. So it's either is you do a urinalysis, there's blood in the urine, but you need to know that it could either be there's blood in the urine, but you also need to confirm it with a microscopy to be sure that it's not just hemoglobinuria. So when you go ahead and you do a microscopy and there's still red blood cells, obviously this is hematuria, but in hemoglobinuria there will be absence of red blood cells. And microscopic hematuria is defined as when you basically see presence of 3 or more red blood cells per high power field. And non-visible hematuria seems to be classified into 2 subgroups. We have the symptomatic one and the asymptomatic one. When we say symptomatic non-visible hematuria, obviously this patient does not have visible hematuria. It's only something you probably have noted on dipstick, and patient is also having symptoms. It could be symptoms of LUTs, lower urinary tract symptoms. Maybe the patient is having frequency, urgency, dysuria, and suprapubic pain, or also renal colic. And it could also be asymptomatic. Patients is not having symptoms. It's just an incidental finding on maybe routine check. So visible hematuria and non-visible hematuria, with non-visible hematuria being further delineated into symptomatic and asymptomatic non-visible hematuria. And so it would also be good to also talk about significant hematuria in itself. Significant, what we mean by hematuria being significant is either when you see a single episode of visible hematuria, for someone to have past urine that is bloody, that's significant. If you have any single episode of symptomatic non-visible hematuria, that is a patient, we're not seeing the blood in the urine, we've probably seen it from dipstick and also maybe confirmed with microscopy. But if there's you also need to rule out the absence of urinary tract infection or other transient causes. For women, menstruation could give you a false positive hematuria, so you need to ascertain if maybe a premenopausal woman is presenting with hematuria. You need to ask questions about the last menstrual period. You want to know if she's currently on a period, because that could be the reason. So you want to repeat that urine dipstick or microscopy at another point in a menstrual cycle. And when we have persistent asymptomatic non-visible hematuria, so this person is having non-visible hematuria which is asymptomatic and is also persistent. And when do we say it's persistent? When we have 2 or 3 dipsticks that are positive for non-visible hematuria. So you've done 3 dipsticks and 2 are positive, and you also need to ensure that you've ruled out a UTI or other transient causes. Like I said, it could be menstruation. It could also be food, what the person is eating. Maybe in terms of, someone that is eating rhubarb, beetroots, black grapes, and also medications also, because sometimes medications could also contribute to that. So another way we can classify, hematuria is look at it from the urological perspective and non-urological perspective, which is basically nephrology. upper urinary tract and lower urinary tract as subunits under the urological component. So one way to walk yourself through it is if you're trying to think what could be the cause of this hematuria, you can walk it all the way from you could walk it all the way from the kidneys, the pelvis, the ureter, the bladder, the prostate, and the urethra. And so upper urinary tract, that's more of the kidneys, and lower urinary tract falls below. Non-urological are mostly medical, and a couple of conditions happen there: post streptococcal glomerulonephritis, IgA nephropathy, Alport syndromes, polycystic kidney disease, and the rest. Also, pseudo hematuria is just basically false hematuria, and like patient, somebody that maybe is just due to the fact that he's taking excess of rhubarb, beetroot, or it's just medications that are causing it. Okay, so hematuria can be physiological or pathological. And when we physiological and more of menstruation and uh, the food items, basically, I think that would also fall under physiological, the beetroot, rhubarb, black grapes, etc. Then also there's this exercise induced hematuria that happens, and mostly happens with when you've done prolonged exercise, sort of running, and it's usually seen in people that run on marathons. And it's said that most times it should clear within 72 hours. So you most likely, if you, I mean, you are, and you would have to monitor that person just to be sure that it clears out. And there are a whole lot of things that could contribute to it, because the fact that one person is doing a strength exercise and the runner or the person is not well hydrated in the course of running a marathon, that would also contribute to hematuria. But you would also, the thing is, you need to exclude it and be sure that, I mean, once it clears out, you are reassured that is the exercise related, because it could be another pathology also manifesting at the point where that happened. So, and it has different synonyms: runner's bladder, marathoner's hematuria, stress hematuria, and pathological hematuria, which is one of the ones that we are concerned majorly with. Infections along the urinary tract, neoplasms also along the urinary tract. Systemic processes could also cause hematuria. Hemolysis would be more of hemoglobinuria, because sickle cell anemia, someone with malaria, burns, etc. And also renal stones can also cause hematuria. The common causes that of hematuria we get, that common causes that we should be familiar with: urinary tract infection, bladder tumors, urinary tract stones, urethritis, benign prostatic hypertrophy, which is seen in males, and prostate cancer. And for the common causes of the asymptomatic non-visible hematuria, most of the times UTI is one of the culprits. So that's why when we were talking about the segment hematuria, you want to rule it out and the other transient causes first, to be sure that there's no other sinister stuff, because UTI is one of the common things that will give you an asymptomatic non-visible hematuria. The other causes could be a stone along the renal tract, maybe a stone that is not giving symptoms yet, and also a benign prostatic enlargement. However, it said that up to 5% of patients with non-visible hematuria are found to have a urinary tract malignancy. So that's why you are concerned about hematuria. One of the concerns, it could be something sinister happen. It could be a tumor somewhere along the urinary tract, and you don't want to miss it, because we know that cancers can metastasize. So it's better you pick it up early and treat it as soon as possible. You pick it up early, refer to the urologist or nephrologist, and they treat it as appropriate. Other less common causes are from trauma, radiation cystitis. Either the person has had a tumor around the pelvic region, and there's been also there's also been radiation to the to the bladder also, cause radiation cystitis presenting in hematuria maybe years later. And also parasitic infections, schistosomiasis, yeah, it can cause hematuria, the common infection in Africa. I mean, also genitourinary tuberculosis can also cause hematuria, and tuberculosis can actually affect any part of the urinary tract. So medical causes, I think I've highlighted that earlier. So this is just a picture just to tell us some causes of hematuria, starting from the kidneys. But before the kidneys, I'll just talk about systemic causes like rhabdomyolysis, maybe from someone that has a crush injury, resulting in myoglobinuria, then blood in the urine, hematuria. Also, people with clotting disorders. Then also, one common thing that we see is, we a lot of people are on anticoagulation either for previous DVT, previous PE, or patients on AF with atrial fibrillation. But it said that when you see a patient with on anticoagulation presenting with hematuria, it most likely might just be that it's just anticoagulation is just provoking it. So you need to identify what is causing it. So you probably also have to investigate it. You also have to investigate. So if we look at from the renal angle, we talked about some medical, and we also not forget that tumors can cause it. From the calyx, presence of stones, also tumors. In the ureters, also stones, tumors, transitional cell carcinoma, and in the bladder also stones, urinary tract infection, cystitis, radiation cystitis, mentioned that earlier. Prostate, a benign prostatic enlargement of the prostate, prostatitis itself, and prostatic CA also. In the urethra also, trauma from urethral catheterization can trigger that, and also tumor around there. And from the vagina also, there could also be bleeding in form, which could be physiological in form of menstruation in a premenopausal woman. But if it's in a postmenopausal woman, you need to know what is causing that. And pseudohematuria, pituitary, trypanosome, and the rest. Okay, this is another slide showing a myriad of the causes of hematuria. We'll just highlight a few. Infective endocarditis, is a medical condition, but it also causes hematuria in the sense that it could also cause some immune complex deposition. It could be antibiotic, related, blah blah blah. So that then tumors, Wilms tumor, majorly in children, could also present as hematuria. Endometrial CA for postmenopausal woman could also be a cause. If there's been trauma in form of an accident, that could also cause hematuria. There's this stuff we call decompression hematuria or hematuria ex vacuo, which basically occurs after rapid emptying of an over-distended bladder. So said to occur due to reduction in the intravascular pressure, and most likely bleeding from the capillaries also. Inflammation, we talked about some of these things, structural causes in the form of, polycystic renal disease. It can be adult polycystic kidney disease and all the vascular anomalies there. I mentioned the presence of an aneurysm earlier. Also, sickle cell disease, coagulation disorders, and coagulation therapy. Invasive procedures to the prostate gland or bladder, cystoscopy, someone that has a top or TOPS, and also some toxins like NSAIDs could also prolonged use of NSAID or chronic use of NSAID could also affect the kidneys. Cyclophosphamide and also causes that. And others are genital bleeding, menstruation, Munchausen syndrome, which is when you just fabricate an anus you don't have. Okay, so pseudohematuria I mentioned earlier is hematuria that is basically not secondary. Is false in itself. Is not due to the presence of hemoglobin, due to medications, like I've said. It could be hyperbilirubinemia when you have obstructive jaundice, myoglobinuria, some foods, items such as beetroot rhubarb. I mean, this is something just to highlight hematuria versus hemoglobinuria. And hematuria is more of red blood cells, hemoglobinuria is more of hemoglobin. The color might vary. I mean, hemoglobinuria may be like tea color, dark brown. Hematuria might be red, or different shades like the shades I presented earlier. And the local causes, like we've said, UTIs, stones, malignancies, systemic causes, and for hemoglobinuria, most times things causing hemolysis would cause that. So, patient presents with you with hematuria, maybe in clinic or anywhere. You want to take an history just to identify where is this material coming from. You want to know the onset. Is it sudden? Gradual? Is it something that's been chronic or is acute? You want to know the color. You want to have an idea of the color. You want to know if it's initial, and that is probably coming from the urethra, and if it's terminal, coming from the bladder neck or the prostate. If it's total, it could be coming up from all the way up from the kidneys, or it could just mean that it's from the bladder itself because the bladder is a storage. If everything is bloody in the bladder, everything comes out as bloody urine. You want to know if there's a step pain, I mean, tisuria, suprapubic pain, flank pain. You want to you want to also know if there's a history of lower urinary tract symptoms, and that will be in frequency, urgency, it could be the voiding or the storage lute. This will help you to know if patient has history of BPH and benign prostatic enlargement. You also want to know if this patient has had previous episodes of this hematuria, so maybe it's not something that is new. Also, history of recent procedures, because is it that the patient just had catheterization, just had a cystoscopy, or the patient is just post surgery, and other systemic symptoms, fever, nausea, and vomiting could occur in the setting of urinary tract infection or an obstructed kidney with superimposed infection. Red flag symptoms when you have masses, I mean, weight loss, you want to rule out malignancy, back pain also for maybe a metastatic prostate CA. Also, past medical history would also be good to explore because if the patient has been on medications for benign prostatic enlargement, that could be a pointer. Patient is being managed for prostate CA, that could be a pointer. History of stones in the past. Patient has had radiation therapy in the past for one tumor, maybe around the pelvis, that could also be a pointer. Chemotherapy also, if the patient has taken cyclophosphamide, the analkylating agent, could also be contributory. Drug history, is this patient taking anticoagulants? I mean, or does the patient have any clotting disorders? Also, that will be in the past medical history. And in the social history, you want to explore the smoking history. I mean, smoking is important for the fact that it's a signal risk factor for tumors, especially bladder CA. Then also history of work in some industries, particularly when your patient has been exposed to an industries where they process paint and dyes. That's also very important. I mean, family history you could also of such you could ask, and also family history of some of these syndromes, ADHD, Alport syndrome. I think this is also something similar to what I've explained in the previous slide, and rifampicin, well, we know that already. I saw methyldopa could also cause that. I think causes hemolysis. Metronidazole also. Okay, so if it's not hematuria, what else can it be? I think I've mentioned some of those things earlier. Hemoglobinuria is one thing. So hemoglobinuria, we just see the dipstick, a positive dipstick, no red cells, under the microscopy, myoglobinuria, maybe from a crush injury causing rhabdomyolysis, food items like beetroots, blackberries, rhubarb, and drugs like rifampicin, nitrofurantoin, senna, a laxative, metronidazole. Porphyria also can also cause hematuria, but it said that urine would darken and standing. Bilirubinuria, obstructive biliary disease. This might, you might, other symptoms might give it away: jaundice, itching, mass somewhere. Okay. Okay, so I think it's time to have some interaction, and I would just like us to pop in answers in the chat. What do you think it is? So we'll just go through some case scenarios and just juggle our minds. So case one is a 55-year-old male who has history of recurrent painless hematuria for 6 months. He has had no associated lower urinary tract symptoms or fever. He has an history of smoking of 30 years, 30 pack years. He's got left renal mass on examination. What do we think it could be? I would appreciate if you can drop some comments in the chat. Waiting for our comments. 55-year-old male, history of recurrent painless hematuria for 6 months. Yeah, so Samuel Davis is saying renal CA. Yeah, that's a possibility. Let's explore other people's opinions. Yeah, Ayokunle says renal CA, other differentials, bladder CA, polycystic kidney disease. Yeah, Samuel Davis has said bladder CA is the first differential anyway. Yeah, I think that those are good thoughts. I mean, this man is a 55-year-old man. He's had painless hematuria. He's got 30 years of history of smoking. It could be, and he has a left renal mass. So it could be a renal CA, and it could also be a polycystic kidney disease also. So I think those are two good differentials. But renal CA might be one of on top of the differentials. Okay, let's carry on. So this is a case of a 35-year-old female presenting to the GP clinic with complaints of dysuria frequency and urgency. Hubs Patient's Hubs is stable. The GP has done a urine deep blood of 2 pluses, leukocyte 1 plus, nitrite positive. What do we think? We can pop in some ideas in the comments. Yeah, Samuel Davis thinks it's a UTI, urinary tract infection. Anyone with other thoughts? What could it be? What differentials are running through our mind? Urinary tract infection. It would be nice to have more engagement. I think we're quite a number of people in the chat in attendance from what I can see. So it'd be good to see our thoughts. Any other different opinion from what has been said? It looks like everyone is in agreement with Samuel and Ayokunle. Okay, just carry on to the next one. So this is a 45-year-old male who has history of left flank colicky pain in the last 3 weeks and has had 2 episodes. He's got history of taking over-the-counter medications like diclofenac for pain relief for this colicky pain, and now he's presented in the OPD with a complaint of a single episode of blood mixed with urine, and he's also got this ongoing pain in his left lumbar region. What are our thoughts? What do we think it's? happening here. So Samuel Davis has said is a run-off stone. Any other? What else do we think this might be? Any other thing that could be causing this apart from a run-off stone? Okay, someone has said a left ureteric stone. Someone has said left renal colic, other differential pyelonephritis. Yeah, those are possibilities. Any other thoughts? Any other opinions? So this gentleman is a 45-year-old male. He's got 3 weeks of left flank colic pain, and it looks like the pain is much for him to be using diclofenac, and he's now had an episode of hematuria. Left flank colic pain, 3 weeks, pain, diclofenac for pain relief, and hematuria now. Yeah, urine stone is a possibility. It could be stone along anywhere in the urinary tract, in the renal, in the kidneys, or the ureters. Yeah, other differential pyelonephritis. Yeah, if I mean that could also be a possibility in presence of fever. Also, could also be a possibility. Okay, so let's move on to the next one. So this is a 5-year-old male. He's presenting to the ED with a material of a week and 2 weeks history of back pain. There's history of lutes in the past, recent weight loss of 2 kilos. His hubs is he has an hubs with blood pressure of 160, heart rate is 60 per minute, temperature is 37, respiratory rate is 18. Urinalysis done in the ED, blood shows 2 pluses of blood, nitrite positive, leukocyte positive. He's got a past medical history of hypertension, and he's taking amlodipine and indapamide. Can we share our thoughts on what is running through our mind? What do we think this could be? Let's keep the let's keep suggestions running in the chat box. Seven 5-year-old male presents to the ED. He's got hematuria of a week, 2 weeks history of back pain, and history of lower urinary tract symptoms in the past. Recent weight loss of 2 kilos, ups blood pressure 160, heart rate 60 minutes per minute, temperature 37, respiratory 18. Urinalysis showing 2 pluses of blood, nitrite positive, leukocyte positive, hypertensive. So someone thinks, Samuel Davis thinks it's a prostate CA with a background UTI. Any other contrary or similar opinions? Is everyone in agreement with Samuel Davis? Abib Abdul Rashid thinks it's a prostatic CA. Yeah, so we have two prostatic CAs, two people thinking it's prostatic CA. Any contrary opinion or similar opinions? I think everyone is in agreement with Samuel and Abib. Okay, Selena says prostate CA with obstruction causing UTI due to urinary retention. 75 years old, prostatic CA, calculi, slow leaking AAA by Ayokunle. Yeah, okay, those are good thoughts, I must be honest. Yeah, looking at the demographics, he's a 75-year-old male. He's got hematuria. He's been having history of lutes in the past, and he's now had recent onset of back pain. and he's had recent weight loss also. Recurrent, history of road in the past. Those demographics, one, support prostate CA. Symptoms also support prostate CA. And now he's got an history of back pain. Sometimes prostate CA might just present to you with back pain, which is indicating metastasis. And he's also got weight loss. So prostate CA is a good, differential. And also, I mean, calculi, yes. It could be a calculi also, given the fact that he's got hematuria and he's also got back pain. Because if he's got costovertebral tenderness, that might be his back pain also. But in this kind of scenario, you don't want to miss a prostate CA also. You don't want to miss a prostate CA. And now his analysis is showing blood pluses, nitrite nucleoside positive. It could also be a prostate CA presenting with hematuria, and he's also got a UTI on top of all of this. And like someone said, it could be a calculi or causing all of this. Yeah, those are good thoughts. Investigations would make the picture more clearer. And also, someone mentioned slow leaking abdominal aortic aneurysm. Yeah, it's possible. It's possible. Hypertensive patient presenting presenting to presenting to the ED, elderly male, 75-year-old male, is hypertensive on medications. It could be, but I think it's one of the things you should put at the back of your mind sometimes when these adult males background hypertension presents, because sometimes you can sometimes think about the things that can kill the patient fast, so that, like, am I missing anything? So sometimes it's good to also think out of the box. Abdominal aortic aneurysm is something that happens, and it can progress rapidly, and patient can die. And also, someone can argue that, okay, this blood pressure 160, are you sure this person is not leaking blood somewhere? Heart rate is 60. Quite on the low side. Yeah, so I think that's a good differential to also put in mind, especially when patient is hypertensive. Maybe he's got a high blood pressure, blah blah blah. Okay, so let's carry on. Thank you guys for the thoughts and the opinions. So the case 5 is an 85-year-old man. He's got a history of recurrent UTI and has been referred by the GP. He's had 2 episodes of UTI treated by GP with antibiotics, and he had dipstick hematuria in those 2 episodes, and he's finished the last course of treatment. Hematuria has not resolved. He still has lower urinary tract symptoms, dysuria. He's otherwise fit and well. He worked in a dye and paint factory in his 20s. He smoked for 60 pack years. His obs are stable, but the urine dipstick has come out as blood 2 pluses, leukocyte and nitrate also 2 pluses. What is running through our mind? Okay. Ayokunle says it's bladder CA. Yeah. Any other similar or contrary opinions? Why do we think it's bladder CA? Anybody with similar or contrary opinions? Also needs to have a bladder scan. Could have chronic retention given symptoms. Yes, that's possible. Yeah, because some of these people, 85-year-old male, okay, do I want to wait? Someone said dye and paint gives it away. Yeah, those are clinchers. He's worked in a dye and paint factory. He's a smoker. So I said dye paint smoker. Yeah. So bladder CA is a huge possibility. Yeah. You don't want to miss this. This guy will probably have to be referred to the urologist under the 2-week wait, so you can see them ASAP. Yeah, so it's most likely a case of bladder CA, given the fact that he smoked for 60 pack years, worked in a dye and paint factory, and this is a case of recurrent UTI not responding to antibiotic treatment. Okay, so we move on. How do you want to assess someone that you've seen with a significant visible hematuria? Patient is bleeding, obviously. Uh, Cases like this, you also want to use your ABCDA approach. Go through it systematically. Check your hair. Yes, airway patent. Patient speaking with you. Is in any respiratory distress. B. Assess breathing. If it's fine, patient breathing fine. It's got good oxygen saturation. If it's good, got good oxygen if it's got low oxygen saturation, give him oxygen. C, circulation. So if someone is bleeding, you want to really know what is happening in your circulation. You want to find an idea of what the heart rate, pulse, blood pressure is. If the patient is tachycardic, blood pressure is 90/60. Means, I mean, maybe there's an significant ongoing blood loss. You're worried about that. You want to ensure if you get an IV access, so that you can get samples, baseline, full blood counts. You want to get a CRP. You want to check renal function, use and ease. You also want to check the clotting profile. You want to have a group and table also, because this patient might need transfusion ASAP. You want to do a VBG, gives you venous blood gas, gives you an idea of the HB, gives you an idea of the lactate, give you an idea of the pH also. Yeah. D is basically assessing consciousness, GCS of this patient. You can check for the sugars for completeness sake. E, E is basically you exposing this patient and trying to go through assess the patient systematically, check for periorbital fullness or peripheral edema, purpura or peteke. This is just more, this could be pointers to other things. So it's good to, check the other, expose and examine. So you don't want to forget to do your abdominal examination, because that could reveal a couple of things to you. Mass in the flanks, suprapubic mass, suprapubic pain. You also want to do your urogenital examination also. And importantly, you don't want to forget the digital rectal examination, especially in men. You want to check the size of the prostate, because that could also be a pointer. Then, while one of the rules of doing ABCD is you also want to intervene once you have identifying a problem. So this patient already has a sigma visible hematuria. If he's not got clots at the moment, good. You want to catheterize this patient ideally with a 3-way catheter, and immediately do a urine dip, send for a urine microscopy culture and sensitivity. In a case where there are presence of clots, it will be good to do a bladder washout, at least to clear the clots immediately, so that you can have a free flow and avoid any obstruction. And in some cases, you might need to do a continuous bladder irrigation. Additionally, it's good to do a PSA. And it's also good to know that PSA is age. You need to look at it in respect to age, and also counsel the patient appropriately, because there could also be false positives. Urinalysis, yes, you want to check presence of white cells, leukocyte esterase, nitrite. Your urine microscopy, are there presence of red cell counts, dysmorphic red blood cells, more pointers to glomerular origin. You want to do imaging, which we'll talk about, basically ultrasound, CTKUB, and deranged renal function. If your user needs a back, patient has got abnormal, high creatinine, urea. You might also want to check the albumin creatinine, protein creatinine ratio. That would help you to know if it's some glomerular things happening, issue happening. And when there's a medical cause, you want to let the nephrologist know ASAP, especially in the presence of when you have proteinuria with hematuria, and those that are less than 40 years old with hypertension, or someone that's got a chronic kidney disease already. Okay, so these are pictorial representations of some of the things you use when you find yourself battling with a case of hematuria. So we have from the left, we have this 3-way catheter, and we have another 2-way catheter and a 1-way catheter. So this is the 3-way catheter you typically use to when the patient has got hematuria. So this is the catheter itself. This is what's used to inflate the balloon. This is a channel for urine, and this can be for your continuous bladder irrigation. This is a two-way. This is for the urine out. This is for the balloon, and this looks like a silicone catheter. This is a one. Looks like a one-way catheter, and this is another good thing that you need to be familiar with. Oh, sorry. This is the bladder syringe. So if somebody's already on a three-way catheter, is I mean, nurse calls you. The nurse just calls you and tells you that the urine is not flowing because it's got clots in the bag. Blah blah blah. This will be helpful to do your bladder irrigation to dislodge the clots and ensure the urine is flowing again. Okay, so just to highlight, differences between glomerular and extraglomerular bleeding. It's more of like urology versus non-urology. So red cell counts may be present in glomerular. Dysmorphic red blood cells is usually something that is associated with glomerular. Proteinuria also may be present with that. So red cell counts most times absent in extraglomerular. The red blood cells retain their shape, so they are still uniform in extraglomerular. Proteinuria most times may be present in glomerular. In extraglomerular, most times may be absent. Clots absent. Extraglomerular may be present. Color different shades, maybe red or brown, maybe red. Okay, so this is a bladder irrigation setup. So if you want a continuous bladder irrigation setup, for instance, a patient has had TURP, is likely going to have some hematuria because you've just operated on the prostate. The patient is likely to have bleeding. So to prevent clot retention, which would cause urinary retention, you don't want that to happen. Most times you want to set up a bladder irrigation. So if you look at this picture, it might not be, very clear. We have two bags of saline here. This is the first. Sorry, this is the first one. I'm highlighting. This is the second one. Then it's got the set, the given set that you attach. But yeah, it has like I'm sorry, it's not very clear. If you can appreciate the white tips here, it's like the clamps, just like the way, for you to clamp one of the given, one can be flowing and you clamp the other one, and you control the rate depending on how you want it. So you can see it's attached to this is actually a three-way catheter. I got this from the video, this YouTube video. So in our spare times we can watch it basically. So how this differs from a bladder washout is the bladder washout is more of you using the bladder syringe and pushing saline into the bladder, especially when you have clots, so that you can dislodge possible clot in the catheter itself or in the bladder itself, so that you can have free flow and there's no obstruction. So hematuria, we know it's got so many things that could cause it, but we'll tailor our investigations now to things relating to urological causes. As a general rule, patients with hematuria would require imaging of the upper urinary tract. In form of, it could be ultrasound. The good thing about ultrasound is non-invasive, doesn't have radiation, it's safe for children, it's safe for pregnant women. You can use it as your first line of choice to assess, compared to CT KB, CT urogram, basically, which is more you have to use contracts. Some people can react to contracts. Some people's renal function might not, depending, might be bad, such that you want to consider if you want to actually want them to go for a CT KEB. And another essential thing for investigating hematuria is a cystoscopic examination, which could be rigid or flexible. And sometimes you can also take a biopsy, especially when there's a bladder mass. You want to take a biopsy and send it to the pathologist so they can identify it. Another thing they do again is urine cytology, but most times it's not often done because they say he could also miss some other tumors in the bladder. Yeah, so flexible cystoscopy is like, oh, sorry, there's this typo here, is one of the gold standards. So flexible, it's just like endoscopy. You're doing an upper GI endoscopy or a lower GI endoscopy. So it's just like a thin tube going through the urethra to visualize the urethra and the bladder. And flexible basically is done locally. Using local anesthesia, and rigid will be more of like spinal or GA. And like so you also need to do an imaging to identify a couple of things. Mass. These imaging techniques will help you to rule out a possible mass, a possible stone. You could also do, an X-ray for the radio to help you identify the radiopoic stones. But CTKB will definitely identify most of these things very well for you. It would help you know if there's an ongoing infection, see if there's perinephric stranding, etc. And if there's a mass somewhere, if there's an aneurysm, it will probably pick all of these things. So it's more, to delineate deletions more than the ultrasound. So initial investigations for a patient with symptomatic non-visible hematuria and persistent. So someone who's got a symptomatic non-visible hematuria, we need to exclude the UTI and other transient causes, like I said earlier. You also need to check that their renal function is good. So plasma creatinine and AGFR. You need to also measure, check for proteinuria, do the PCR and ACR. Those are values, cutoff values. Measurement of blood pressure. When most of this, if the blood pressure is elevated, proteinuria is there, plasma creatinine is off, EGFR is off, you might want to just involve the nephrologist and let them carry it across. So when you refer to urology, this is very good for us to take note of. You want to refer to urology. This is using the NICE guidelines, basically. So if the patient is 45 years old or more, and they've got an unexplained visible hematuria in the absence of a urinary tract infection, or the patient has a visible hematuria that seems to persist or recurs after treating the urinary tract infection. I think one of the scenarios you mentioned was similar to this. Yeah. And you've got a 60-year-old man or patient, and 60-year-old or more, and has unexplained non-visible hematuria. So non-visible hematuria, which is unexplained, that is in the absence of a UTI. And either dysuria or a rest white cell count on a blood test. As a GP, as a primary care physician, you want to send this patient ASAP using a 2-week wait and let the urologist see. He said, the last one is consider non-urgent referral for bladder CA in people more than 60 years or 60 years with recurrent or persistent unexplained urinary tract infection. Yeah. So those are guidelines that have been made to help us with our work and make it more easier. So when you see some of the people that fall into this category, just check the NICE guideline and see if they fall into this cadre. So if the patient has had a urological cause excluded, the GP or the primary care physician has sent the patient to you, and you feel like you've seen this patient, you've investigated this patient, you can't find a urological cause, and they don't fall into this guideline we just discussed, you might need to you will need to refer to nephrology. And some of the things you need to consider: look at the age, 40 years or less, EGFR less than 60 mils per minute. It's got significant proteinuria. It's got a blood pressure of more than 140/90. You would want to send to the nephrologist. So, like I said earlier, hematuria is basically a presentation, and it's not a diagnosis in itself. So you need to find out what is causing this hematuria so that you can treat the underlying cause. So the management of hematuria is basically the treatment of the underlying pathology. And hematuria has a myriad of causes, so you really want to get the problem behind the hematuria and solve it. So some things you can do is you want to review existing anticoagulation therapy for those that are on anticoagulants. You want to discuss with the anticoagulation team. If the patient has a clotting disorder, you want to correct that. those that have hematuria and they are dropping their HBs, I mean less than 70, patient is symptomatic. Those that have cardiovascular problems and HB is less than 80, you want to consider transfusion. And also, when when the patient has significant hematuria, especially those with clot retention, you want to sort it out ASAP, most likely because it can cause acute urinary retention, which is another problem itself. And such patients you probably want to send to the ED so that the urologist can see and probably admit, and so they can take care of that. And most of these patients will always require a three-way catheter. A three-way catheter is very important because it will help you with your continuous irrigation and also to clear your clots. And so, like I said, the management of hematuria is based on what is causing the hematuria. So options are the management to be solely dependent on what is causing the hematuria. So analgesia, someone has got a renal stone, and that's what you're suspecting. Analgesia will be of help. Someone has got a renal stone with obstruction and infection, antibiotics will help. UTI, antibiotics will help. Catheterization will help with someone with ongoing hematuria. You want to do a bladder washout versus irrigation. We've distinguished between what a washout is and an irrigation. The irrigation, we talked about the setup earlier, which is basically the continuous bladder irrigation. You have two bags of saline, got like an IV drip connecting to the three-way catheter to help you irrigate. If it's due to stones, they are depending on the size of the stone. That's what will determine management. So these are some of the management modalities. Benign prostate enlargement would also be more of either medical or surgery, depending on that. Sometimes not true waiting. Prostate CA will be dependent. It would either be medical or surgical, but it will be dependent on the staging of the tumor, basically. So those are some of the modalities. So this is our post-assessment questions. I mean, we've come to our end. I think we are 3 minutes past time. Sorry about that. And we can just try to answer the polls again, just so that we can see how I mean what we knew before and what we've known after. Hopefully, I think the questions should pop up now. Okay, so I think the poll questions are popping up. I've just seen the first one on my screen. Hopefully, the second one comes in soon. So we can call it a day and have a good evening. Cystoscopies. I can see a question in the chat. I'll attend to that in a bit. Cystoscopy is always okay. Sorry. The second question is. I mean, I think there's another poll coming up now, so we can answer that. So in the meantime, while we are answering the polls, we can also drop in our questions so that people can. Okay. Can pop in your questions as you answer the polls. Okay. I think we're probably done with all. So there's a question in the chat box I saw initially. So someone said, which fluid is ideal to use in bladder irrigation, normal saline or sterile water or something else? I think from what I've seen so far, normal saline is what is used so far. So like the picture I showed earlier, those were 2 bags of normal saline, 3000 cc. So they are not like your regular saline bags that you see. So when you see huge bags of saline beside a patient attached to a catheter, just know that, and you're seeing a bloody bag. It's like that's a bladder irrigation setup, continuous bladder irrigation setup. Yeah. And there was another question I saw. We can keep popping out questions. So we'll call it a day in a bit. I saw a question and I can't remember. There was something about SGLT and UTI. Can UTI risk be aggravated by treatment with SGL2 inhibitors? I think that's sodium glucose transport 2 inhibitors, which I think we use for diabetes and prognostic medications for heart failure. Well, diabetes in itself is a risk factor for UTI, but I'm not sure if SGL2 inhibitors can UTI risk be aggravated by treatment. So treatment with SGL2 inhibitors aggravating or causing the UTI. I'm not sure of that. I've not read of that. If anyone has any information on that, please kindly share. And yeah, so anyway, Ayokunle has just shared something with us. Cystoscopy is required for all cases of hematuria. So NICE guideline is a good guide, but all visible hematuria without a clear known cause should have a cystoscopy and an upper retracting imaging. Yeah, like we said, as a fundamental rule, do an imaging. If it's not within your purview to do that, send it to the urological team and let them sort that out so that they can have you can put this suggestion in. You think this patient should have a cystoscopy and an upper urinary tract imaging. Yeah. So let's not forget that a cystoscopy is important because that could just be you picking a cancer. That could help you pick a cancer and just prevent that. Also, important to mention that for Emma, please just keep dropping your questions. Hopefully, we'll close in the next few minutes and we can end the session. Also, important to mention that for hematuria, causes with possible risk of urethral damage, urethral catheterization must not be done. Also, important to mention that for hematuria, yeah. So, I think what this person is saying is, I think what Samuel is saying is, if you know that there's been a traumatic, there's been a urethral damage either from traumatic catheterization in the past, and the patient has difficult urethral catheterization, and also maybe history of hematuria, be very, very careful in approaching such a patient because there might have been fibrosis, strictures. It might be very difficult for you to catheterize that patient again. So if you try, you probably will provoke bleeding, cause more fibrosis, and cause more strictures. So it's better you just send because they might have to do a suprapubic cystostomy for that patient. So let's also take note of that. Those are, good suggestions from some of my colleagues here. Yeah. Do we have any questions? And it would be nice for everyone to please provide a what do you call it, a feedback on so that we can improve the sessions going forward. Yeah. I mean, I think I didn't dwell much on trauma as a cause of possible material. So hematuria could also be as a result of trauma to the back, like patient. Maybe there's trauma to the renal, kidney itself, the pelvic region, and also falling astride could also cause hematuria itself. Someone has just pointed it out. Thank you very much, for Samuel Davis. Uh, it was not. I didn't mention it in the presentation. Falling astride is a good is a risk factor for urethral trauma. So if someone presents to you with falling our stride, that's most likely, I mean, trauma to the urethra. So when you're saying tip of blood, blood at the tip of the meatus or at blood at the urethral meatus, that can be suggesting following a trauma, that is for especially falling our stride. That could be. So you might want to speak with your urologist. How best do you think you want to categorize such patient and monitor urine output in that patient? So I think we should take note of that. I mean, do we have any questions, further questions, suggestions? I appreciate the fact that people are putting in suggestions, and also so it means that, because I think it's a big topic. I can't say everything. So do we have any further questions? We just call it a day. Any questions? I'll just give 1 more minute for a question, then I think we'll end the session, and that'll be all. All right. I think we'll have to call it a day. Thank you to everyone who has joined. Please, we would appreciate if you can provide feedbacks so that we can see how we can better improve the sessions going forward. It's been a delight having everyone on the call. Yeah. So thank you very much. I think we'll call it a day already. I think there are 2 messages in the chat. No, so it's more of the feedback and everybody say thank you. All right. Thank you, everyone. Do have a lovely evening and a restful night. Bye.